Hello, everyone. Hello, Chairperson. Well, my presentation today is a solid proof that everything related to women is a little bit complicated, even this presentation. So we're going to start by women's sex hormone and the kidney, the neglected controversy. What we already know before is that the chronic kidney disease population in women is often associated with various hormonal disturbances as infertility, premature menopause, and other menstrual disorders. And what we already know is that the nephrologists are the primary care providers for their patients, but what we don't know is the perception of the nephrologists regarding these hormonal disturbances issues in the female chronic kidney disease populations. That's why the Canadian Society of Nephrology has adopted this survey to try to evaluate the perceptions of the nephrologists regarding these hormonal disturbances issues and the awareness of the nephrologists regarding these problems. And the results were there was a high level of uncertainty among the nephrologists with regard of the role of hormonal therapy in women with chronic kidney disease. But this survey was a continuation to this study that was developed 10 years ago, a study of 100 women with chronic kidney disease to assess the prevalence of gynecological disorders. And the results were that 58% of women, of these 100 women, had menstrual disorders with uncontrolled menorrhagia. 35% were menopausal, including 7 women under the age of menopause. Menopausal symptoms were undertreated, 14-fold increase in premature ovarian failure due to CKD and cyclophosphamide therapy, 22% were subfertile, and 10% had an abnormal smear with cervical dyskaryosis. And contraceptive advice had often been absent or inappropriate. What about our own guidelines? What does our own guidelines say about these women problems? Unfortunately, due to lack of data, our own guidelines refer this to the North American Menopause Society due to lack of data. So our presentation will take 2 routes. How does the sex hormones affect the kidney, and how does the kidney affect the sex hormones? Starting by how the kidney disease affects sex hormones. Okay, as chronic kidney disease progresses, the gonadotropin releasing hormone tonic release seems to be intact, but what seems to be affected is the cyclic release of the gonadotropin releasing hormone, leading to loss of pulsatile pattern of the gonadotropins, leading to loss of the pulsatile secretion of the estradiol and LH and FSH. On the other hand, there is an increased secretion of dopamine due to loss of sensitivity to the dopaminergic activity, and there is a decreased renal clearance of prolactin. Okay, these hormonal disturbances, are they ovarian or hypothalamic? This is what we need to know, but we need to understand a little bit of the physiology to understand this part. Okay, as we can see in this graph, that the luteinizing hormone and the FSH and the mid-cycle, whenever they are peaking, we find there's a sharp decline in the estradiol level and the progesterone level. And on the other hand, when there's a peak for the progesterone in the other half of the cycle, when there is a high level of progesterone and estrogen, the luteinizing hormone and the FSH declines sharply due to the negative feedback mechanism. So from this, we can understand that whenever we administer an anti-estrogen like the clomiphene citrate, the LH and the FSH rises. And this proves that the ovaries are functioning very well, and the problem seems to be in the hypothalamus. Fact number 2 is that upon the administration of estrogen, the expected initial suppression followed by the normal surge does not occur, and this again proves that the ovaries are functioning very well, and the menstrual irregularities are likely the consequences of hypothalamic and pituitary rather than the ovarian. The hyperprolactinemia, as we said before, it's due to decreased renal degradation and clearance, which is significant in the healthy kidney, as the renal vein is approximately lower 16% than the renal artery in healthy individuals. And there is also an upregulated production of prolactin due to CKD inhibition of dopaminergic activity. This will also lead to the decrease in the normal cyclic GnRH secretion, resulting in loss of pulsatile LH and FSH release. What about sex hormones affecting the kidneys? Hormonal therapy in women can be divided into three: the premenopausal, which are the oral contraceptives and the cycle regulations; postmenopausal as the hormonal replacement therapy; and the SERMs, the selective estrogen receptor modulators. The effects of oral contraceptive use in the renal and systemic vascular response. The oral contraceptives increased plasma angiotensin II, but only with very minimal hemodynamic consequences, and this is due to estrogen-mediated angiotensin type 1 receptor down-regulation. They increased the renal tubular response to changes in sodium, leading to increased GFR, increased nitric oxide, increased renin-angiotensin, and all those together has an increased risk for the diabetic nephropathy. This study by the American Diabetes Association has been evaluating the use of oral contraceptive pills in both diabetic and non-diabetic patients. And it showed that both non-diabetic and diabetic oral contraceptive users have an increased renal plasma flow in response to captopril compared with the OC non-users. So it showed that 18% of the oral contraceptive users developed macroalbuminuria compared with only 2% of the oral contraceptive non-users. As we can see in the non-diabetic group, the OC users compared to the non-users, there is a higher renal plasma flow, and similarly in the diabetic group, the oral contraceptive users has a higher renal plasma flow. Also with the macroalbuminuria, there is a high rate of macroalbuminuria during the oral contraceptive use compared to the non-oral contraceptive use. Another large cross-sectional study has evaluated the use of oral contraceptive in CKD and hypertension. They found out that the blood pressure returns to baseline with cessation of oral contraceptive 6 months after oral contraceptive withdrawal. The GFR normalized, but there was no change in the albuminuria observed in 13 women. The dose and type of progesterone have also been implicated in the increased renin-angiotensin activity. What about the selective estrogen receptor modulators, which were called previously the anti-estrogens, but since they have mixed agonist and antagonist effect, the name was redesigned to be called selective estrogen receptor modulators. The famous three selective estrogen receptor modulators that we know is the tamoxifen, raloxifene, and tormimifene. They are competitive inhibitors of estrogen binding to estrogen receptors. This is like the biggest study that has been made in a chronic kidney disease population on one of the most common SERMs, which involved 7,705 osteoporotic women with chronic kidney disease. And it showed that there was a slower rate of increase in serum creatinine compared to placebo, reduction in risk of breast cancer. There was no increase in risk of endometrial cancer, and there was a reduction in vertebral fractures. On the other hand, of course, there was an increase in thromboembolic events, hot flashes, edema, and cramps. What about the hormonal replacement therapies? The forms of hormonal therapies are estrogen alone, combined estrogen and progesterone, and the SERMs, as we said before, and the gonadomimetics, which has an extra androgen. In non-renal patients, observational data showed the beneficial effect of hormone replacement therapy on the cardiovascular risk factors. But on the other hand, the randomized control trials didn't prove the same. The heart and estrogen progesterone replacement study and the estrogen replacement and atherosclerosis studies showed that the therapy does not reduce the overall incidence of the coronary heart disease. What about our renal patients? The American Journal of Kidney Disease, hormonal therapy was associated with a 19% reduction in albumin-creatinine ratio, and there was suggest that hormonal therapy is associated with a reduction in urinary albumin and excretion in postmenopausal women. What are the indications for hormonal therapy in women generally? Number one, first-line therapy for the relief of menopause symptoms is an appropriate candidate. Number two is the prevention of bone loss. Three, primary hypoestrogenism following premature surgical menopause without contraindications, and genitourinary symptoms as vulvovaginal atrophy. What about the hormonal therapy position statement that the North American menopause, that our guidelines referred us to? It said that a conjugated equine estrogen of a dose 0.625 milligrams and only one progesterone 2.5 milligrams is the required dose for hormonal replacement therapy, and the progesterone here is for endometrial protection because of the unopposed endometrial exposure to estrogen increases the risk of endometrial hyperplasia. Regarding the diabetes, metabolic syndrome, and body composition, the Women Health Initiatives found out that there was a significant reduction, 19%, in the incidence of type 2 diabetes mellitus in patients who have been supplied with the hormonal therapy. And another meta-analysis found that the combined hormonal therapy reduced type 2 diabetes mellitus in 40% of patients. It also showed that the hormonal therapy can attenuate the abdominal adipose accumulation and the weight gains that are often associated with the menopause transition. What about the risk of coronary heart disease, mortality, and stroke due to low estradiol levels? The guideline said that the more that women who are younger than 60 or who are within 10 years of menopause onset, the more favorable effects of hormonal therapy of coronary heart disease and all-cause mortality should be considered against all potential rare increased risks of breast cancer and venous thromboembolism. But on the other hand, women who are older than 60 years old and who are more than 10 years from menopause are at higher absolute risk for coronary heart disease and venous thromboembolism, but put in mind that personal and familial risks should be taken in mind when doing this. The hypoestrogenism as a cardiovascular risk factors, low estradiol, postmenopausal women are significantly younger when they experience cessation of menses. The earlier the age of menopause, the higher the risk of cardiovascular mortality. So, this study is evaluating the age of menopause regarding the cardiovascular mortality, a cohort of 12,000 patients with postmenopausal women follow up to 20 years. The risk of cardiovascular mortality was higher for women with early menopause than those with late menopause. And each year delay can decrease the risk by 2% for coronary heart disease and cardiovascular mortality. As for our kidney patients, the clinical outcome of low estradiol in the female population, there was a decreased bone marrow density, decreased kidney function, increased cardiovascular risk, decreased HDL, infertility and ovulation, menstrual disorder, premature menopause, and decreased sexual desire. The use in chronic kidney disease, but these patients were end-stage renal disease, 13 patients compared with control women who didn't take the hormonal therapy. After a follow-up of 12-month period, the 13 women all resumed regular menses. There was a decrease in prolactin level, significant increase in the Lamberstein BMD, and increased libido and quality of life. For those women with chronic kidney disease on hormonal replacement therapy, the estrogen dose should be 50 to 70% lower than those who are with normal kidney functions, with the same equivalent effect. Our take-home messages: nephrologists recognize an impact of CKD on sex hormones in women, but report no frequent discussion about related issues with patients. The sex hormone-related issues resembles an important knowledge gap in nephrology. Oral contraceptive pills has been linked to a greater risk of diabetic nephropathy. Efficacy and safety of hormonal therapy in renal patients is not fully recognized. The guidelines concerning indications, safety, and administration protocol for renal patients to be established. Thank you very much.